ആരെങ്കിലുമൊക്കെ വന്നിട്ടുണ്ടോ എന്ന് നോക്കട്ടെ.
7 പേര് തന്നെ ആയിട്ടുള്ളൂ. 8 മണി ആയതല്ലേ ഉള്ളൂ.
ഫൈസലും ചേർന്നിട്ടില്ല. 8 മണി ആവുന്നതേ ഉള്ളൂ കേട്ടോ.
ഇല്ല, 8 മണി ആയിട്ടുള്ളൂ, ജസ്റ്റ് ആയിട്ടുള്ളൂ.
അതെ അതെ, ഞങ്ങൾ ജസ്റ്റ് ആവുന്നതേ ഉള്ളൂ. അത് 8 മണിക്ക് എന്ന് പറഞ്ഞാൽ നമ്മളുടെ ശീലം വെച്ചിട്ട് 8 മണിക്ക് തുടങ്ങൂല എന്നാണ് എല്ലാവരും.
അതെ അതെ അതെ.
പിന്നെ ആദ്യം എന്തെങ്കിലും ടോക്കൊക്കെ ആയിരിക്കും, അത് കഴിഞ്ഞിട്ട്
ഈ പ്രോഗ്രാമിന് കേറാന്നുള്ളതാണ്.
അതെ അതെ, അതാണ് ഇപ്പോഴത്തെ ആളുകളുടെ പോളിസി. അത് പ്രോഗ്രാം നീട്ടിക്കൊണ്ടു പോകുമ്പോഴുള്ള പ്രശ്നമാണ്. സാദിഖിന്ന് വിളിച്ചിട്ട് ആരെങ്കിലും ഒക്കെ കിട്ടിയിരുന്നോ? സാദിഖ് ചിലപ്പോ ആരെങ്കിലും ഫോൺ ചെയ്യാറ്. കുറച്ചു പേരും കൂടെ ജോയിൻ ചെയ്യട്ടെ എന്ന് വെക്കാം അല്ലേ, തുടങ്ങാൻ ഒരു 5 മിനിറ്റ്.
അതെ സർ.
Hello, Juman. Good evening.
Juman.
Hello.
സംസാരിക്കുമ്പോ എല്ലാവരും സ്വയം അൺമ്യൂട്ട് ചെയ്യണം. അൺമ്യൂട്ടിങ് അവനവനെ ചെയ്യാൻ പറ്റുള്ളൂ. ഫൈസൽ.
Good evening, sir.
Good evening. Jose Anthony, good evening. ചെയ്തിരിക്കണല്ലേ, ഓരോരുത്തരായിട്ട് ജോയിൻ ചെയ്യുന്നുണ്ട്. നമുക്കൊരു 8:05 ആവുമ്പോഴേക്കും തുടങ്ങും.
I'll join late. Be patient. Yeah.
ജിബു വന്നിട്ടുണ്ട്.
ഇത് 13 പേരൊക്കെ ആയി, ഓരോരുത്തർ ജോയിൻ ചെയ്തുകൊണ്ടിരിക്കുകയാണ്.
ജിബു എത്തിയിട്ടുണ്ട്.
ജിബുവിനെ നേരത്തെ വിളിച്ചിട്ട് കിട്ടിയിരുന്നോ?
ഇല്ല, ജിബുനെ അതിന് വിളിച്ചിട്ട് കിട്ടിയില്ല. 8:10 തുടങ്ങാം അല്ലേ?
5 ആവുന്നേ ഉള്ളു. 13 പേരായി. ഒരു സാദിഖ് 8-10 വരെ വെയിറ്റ് ചെയ്യണമെന്നില്ല. ഇപ്പൊ ഒരു 14 പേരൊക്കെ ആയി. നമുക്ക് മീറ്റിംഗ് തുടങ്ങി വെച്ചാലോ?
തുടങ്ങാം സാർ അല്ലേ?
തുടങ്ങാം.
അതെ, അപ്പം ഇനീഷ്യൽ പ്രോഗ്രാം കഴിയുമ്പോൾ ആൾക്കാർ എത്തിക്കോളും.
അതെ, ഞാനൊരു ഇൻട്രൊഡക്ഷൻ പോലെ പറഞ്ഞിട്ട് തുടങ്ങാം. സാദിഖ് ഫോൺ ചെയ്യണമെന്ന് തോന്നുന്നു. സാദിഖ് തുടങ്ങട്ടെ?
തുടങ്ങല്ലേ സാറിന്? 14 പേർക്കായി.
തുടങ്ങാം.
അനിയസും കയറിയില്ല. അനിയസും കയറിയാ? അനിയസും ഡോക്ടർ കയറിയാ?
ഇതൊന്നും കയറിയിട്ടില്ല. പുള്ളി ഫോണിലൊന്ന് വിളിച്ചു നോക്കിയാ?
ഓക്കെ.
കഴിഞ്ഞ പ്രാവശ്യം പോലെ വരരുത്. പിന്നെ ഒന്ന് വിളിച്ചിട്ട് പുള്ളി റെഡി ആണെങ്കിൽ നമുക്ക് തുടങ്ങാം. ഇങ്ങനെ പറഞ്ഞാൽ മതി. ഒരു തുടക്കത്തിലൊരു ചെറിയൊരു മീറ്റിംഗ് പോലെ ഉണ്ട്. അത് കഴിഞ്ഞ് നമ്മൾ
പറഞ്ഞിട്ടുണ്ട്.
ജോയിൻ ചെയ്യാൻ പറയും.
നിങ്ങൾ ജോയിൻ ചെയ്യാന്നാല് തുടങ്ങല്ലേ? ഓക്കെ സാർ. ഇപ്പൊ ജോയിൻ ചെയ്യണം. തുടങ്ങാം.
Today, IAP Malappuram is observing World Autism Day. Today we have a speaker, Dr. Hani Hassan. Before starting the program, let me talk a few words as introduction. Autism spectrum disorder is a complex developmental condition that involves persistent challenges in social interaction, speech, and non-verbal communication, and restricted and/or repetitive behaviors. The effects of ASD and the severity of symptoms are different in different persons. Autism spectrum disorder is usually first diagnosed in childhood with many of the most obvious signs presenting around 2 to 3 years old, but some children with autism develop normally until toddlerhood, when they stop acquiring or lose previously gained skills. According to CDC, 1 in 59 children is estimated to have autism. In our practice, we are not seeing that many cases in India. autism spectrum disorder is also 3 to 4 times more common in boys than in girls. And many girls with ASD exhibit less obvious signs compared to boys. Autism is a lifelong condition. However, many children diagnosed with ASD go on to live independent, productive, and fulfilling lives. We are starting the program with a silent prayer. Now I invite Dr. Akbar Sadiq for welcome and presidential address.
Thank you, sir. As Joshi sir said, today we gathered in this platform to observe the Autism Awareness Day. Actually, the date is April 2nd. Due to some reasons, due to holidays, elections, and some other reasons, we had to postpone the date and we decided to conduct it today. This year's Autism Day theme is Inclusion in Workplace, Challenges and Opportunities in Post-Pandemic World. And that is the theme, WHO theme of this year's Autism Awareness Day. Today, my duty actually is to welcome you all. Today, the program is inaugurating Dr. Vijay Kumar sir, HOD Pediatrics Medical College, Manjeri is inaugurating the program. I'm inviting him to this program. First of all, I'm inviting Dr. Vijay Kumar sir to this program, and I'm inviting all those who joined in this platform to this program. And now I invite Dr. Vijay Kumar sir to inaugurate the program. Please, sir.
Respected President of IAP Malappuram, Dr. Akbar Sadiq, Secretary Dr. Juman, respected Joshi sir, and all the dignitaries. Today, IAP Malappuram is observing Autism Awareness Day. But because of the COVID resurgence, we couldn't make a physical meeting and we have to restrict ourselves in a Zoom platform. And first of all, I congratulate all the doctors or everybody in Manjeri IAP because they have started observing this program. And as Joshi sir was telling, it is not a rare disease. At least 1 in 60 children are having some features of autism, and we don't have enough facilities to cater all these children. We have an autism clinic at Manjeri Medical College, but that is also, I'm not telling that is not up to the mark. So we are trying our level best to make it a center for Malappuram district. And I'm not extending the speech because we are waiting for a good teaching program. So I declare the program inaugurated, and I wish all the best to the good work by IAP Malappuram. Thank you. Thank you so much.
Now I invite Dr. Dosani to have some words, felicitation for felicitation. Please, sir. Dosani, sir.
Good evening to my pediatric colleagues, respected President, and respected my dear colleagues. Today we are conducting a webinar meeting on autistic spectrum of disorder. Autistic spectrum, both sometimes because of the awareness of the autistics now is aware this special condition and early reference and to the specialist center and what all things we have done for this autistic spectrum. If it's a delay in diagnosis, it will affect the cognitive behavior, speech, and everything. I think we are waiting for a good academics based on the autistic spectrum disorder. by your good speaker. Thank you. Thank you all for the IAP colleagues.
Now, I invite Dr. Faisal to moderate the session, CME. Please, Faisal. Over to Faisal. Faisal, MES Medical College, Pendalmanna. Hello?
Hello. Am I audible?
Yes.
Yeah. Thank you. Good evening, everyone. Respected senior colleagues, Secretary President, and other dignitaries. My dear friends, very good evening to all of you. Today we are observing World Autism Day. As all of you know, autism is a very important neurodevelopmental disorder in children. And it is characterized by defective social interaction and lack of verbal and non-verbal communication, along with some restrictive and repetitive pattern of behavior, interest, and actions in children. So it is very important to diagnose it very early. At least we should have a suspicion, and we should refer to the appropriate person to diagnose it, so that early intervention can be undertaken, and which makes a whole lot of difference in the outcome. So that's the most important thing. For that, we need to know a certain red flags in autism, like lack of eye contact in children, and lack of response to call by their name within 1 year, and absence of joint attention or shared attention, which is one of the most important characteristic feature of or feature of early feature of autism, which means that the child is not able to attract the caregiver's attention to the things, to the interesting things he sees, by either pointing towards it or by eye contact. So that type of behavior is lacking in autism, that is called joint attention. And also there are so many other things like a lot of stereotypical behavior, restrictive and repetitive behavior, like hand flapping, head banging. So all of these things are very important to recognize autism very early, so that we can intervene very early. And that is also make a big difference in the outcome of these children. So I'm happy that IAP has undertaken this in a big way, and we are observing this day. To speak about this, we have an eminent psychiatrist, Dr. Hani Hassan. He is working as a consultant psychiatrist in Government District Hospital, Tirur. And he is hailing from Mankada, a nearby place to Manjeri. And he did his MBBS from Dr. Somerville Memorial Medical College, Karakoram, Trivandrum, and diploma in psychiatric medicine in Government Medical College, Trivandrum. And now he is working as a junior consultant in, as already mentioned, in District Hospital Thiru. And currently, he is, with a short duration of time, he has made a big impact in society. And he has been organizing many events. And he is the district secretary, KGMA Malappuram. Is a mentor in our Responsibility to Children program. There is a program called In Our Responsibility to Children. Faculty in Suicide Prevention Squad by Women and Child Department. Is a mentor in Chiri project by State Police Department, and is a director of Happy Harvard, the Learning and Development Center, Kottakkal. And he's also a mindful trainer. And now the talk will be a very good learning experience for all of us. And I invite Dr. Hani to present this topic. Over to Dr. Hani. Thank you.
Thank you, sir, for the kind words. Am I audible?
Yeah, you're audible. Go on.
Can I share the screen?
Yeah, of course. Sadiq.
Share പറ്റുന്നല്ലേ?
No, Sadiq, make Hani a host so that he can share. Okay. Yeah, it's coming.
First of all, I would like to thank IAP Malappuram for giving me this golden opportunity to present before you the topic autism spectrum disorder and overview. I would like to thank Dr. Akbar Sadiq, the president, and Dr. Juman, secretary, and Dr. Vijay Kumar sir, Dr. Joshi sir, and Dr. Faisal sir, and all other dignitaries taking part in this CME. Am I audible?
Yes, you're audible. Go on.
I would like to start with a story. The story of Choto. There was a lady named Meetu and a man named Kutu, and they are love married couple. And they didn't have a baby for a long time. They prayed and took treatment. Meetu became pregnant. They proposed the name Chotu for the upcoming child. Chotu was born, but did not cry soon after birth. Doctors did a great job and resuscitated him. At the age of 6 months, Meetu noticed that Chotu was not smiling and looking at others so often. Chotu grew. He looks at the pointing hand instead of pointed at objects. And he consistently fails to point at objects in order to comment on or share an experience. Chotu has difficulty with imaginative play and or imitative play. And Chotu has stereotyped behaviors, which are repetitive movements like hand flapping, head rolling, body rocking, etc. Chotu is having a habit of placing objects in a specific order or in a line. And Chotu have resistance to change. For example, insisting that the furniture not be moved or refusing to be interrupted. Chotu does head banging. But Chotu can sing. What is Chotu's condition? So, we are going on to autism spectrum disorders. In 1943, Leo Kanner described 11 cases of autistic disturbance of affective contact. In 1960, much confusion about the nature of autism and its etiology, that is, its relationship to the schizophrenia. Some named it as childhood schizophrenia. And in 1978, Michael Rutter synthesized the Kanner's work and research in new definition served as the basis for the use in DSM-3, Diagnostic and Statistical Manual, published by the American Psychiatric Association. In 1979, in ICD-9, category of psychosis with onset in childhood included as a subgroup of infantile autism. They considered it as a childhood psychosis. In 1980, the DSM-3 came and it's first recognized and placed in a new class of disorders pervasive developmental disorders. And in 1994, DSM-4 and ICD-10 both have pervasive developmental disorder subtypes like autism, Asperger's syndrome, Rett syndrome, pervasive developmental disorder, NOS, and childhood disintegrative disorder. In 2013, the latest DSM-5 came. It has only autism spectrum disorder as a diagnosis. We can quickly move through the pervasive developmental disorder diagnosis, which was earlier in ICD-10 and DSM-4. The age at which we can recognize is very less in, we can recognize early autism, but not others. You can see the autism can be recognized as early from 2 months or 3 months, or others little later. And Rett syndrome showed a female predominance, others have male preponderance. And family history is frequent with Asperger's syndrome, and seizure disorder was very frequent in Rett syndrome. Also, it is common in autism and childhood disintegrative disorder. Head growth and head growth deceleration was found in Rett syndrome. And coming on to social skills were very poor with autism and childhood disintegrative disorder. And communication skills poor in all others except Asperger's syndrome. And loss of skills were marked in Rett and childhood disintegrative disorder. Circumscribed interests were marked in Asperger's syndrome. IQ is normal to mild mental retardation is seen in Asperger's. Otherwise, others show severe mental retardation. And the outcome is fair to good with Asperger's and very poor with the Rett and childhood disintegrative disorder. Coming on to the clinical characteristics of autistic spectrum disorder. As you all know, autism spectrum disorder is a neurodevelopmental disorder with impairments in reciprocal social communication and tendency to engage in repetitive stereotyped patterns of behaviors, interests, and activities. These are the two core features. The impairment in social reciprocal communication and repetitive stereotyped patterns of behaviors were the two core features of autistic spectrum disorder. It arises from the atypical brain development. And impaired reciprocal social communication has three main components. One is social emotional reciprocity. Second is nonverbal communication. And third is developing and maintaining relationships. Impaired social communication also seen with difficulties in joint attention, as I mentioned the case of Chotu. And eye contact difficulty in maintaining eye contact was present. Lack of social intention to communicate with others are seen, and lack of useful speech, lack of social imitative, symbolic, imaginative play. And there is a fascination with sensory stimulus seen in some individuals. And as the child grows, lack of interest in other children and inability to play cooperatively and difficulties in conversation and lack of empathy. Empathy means trying to understand the other situation, put oneself into others' shoes. And there will be rigid thinking patterns, and usually there will be friendship problems. Coming on to the second core feature, that is repetitive pattern. It can be seen repetitive speech, like echolalia and motor symptoms and repetitive use of an object. Excessive adherence to routine and restricted and fixated interest, hypo or hyperreactivity to sensory input. These are the 4 subdomains of the repetitive behavior. For the diagnosis, as per the DSM-5 criteria, all 3 subdomains of the social reciprocal communication plus any 2 out of the 4 repetitive restricted pattern of behavior, as I described. If there is no repetitive pattern of behavior, a new diagnostic criteria of social communication disorder was put forth in DSM-5, which is released in 2013 May. And there will be cognitive difficulties. The intellectual disabilities are very common in autistic spectrum disorders, which ranges from 25 to 50%. The poor language and social comprehension are the other 2 domains which are affected. High functioning autism, there will be non-verbal learning disability. Hyperlexia is a term used to describe ability to read but with little comprehension of the content, are seen in cases of high functioning autism. And usually there will be poor scholastic performance. There will be problems with independent daily living skills, motor coordination, sensory sensitivity, sleep and eating, and mental health difficulties, of course, there will be present. And at-risk behavior, that is aggression and self-injurious behavior, we have seen in Chotu's case, headbanging-like features. And there will be difficulties in scholastic performance. Coming to the prevalence, initially 1 in 100 was seen in systematic reviews from the studies of Fombone, Williams et al., Elzabad et al. But recent studies shows 1 in 54 with male to female ratio 4:1, Maynard et al. 2020. 3% seen in South Korea and Japan. Boys were more affected than the girls, and in clinical samples the ratio is between 4 to 6:1, but community sample shows a low ratio 2 to 3:1. Girls affected with autistic spectrum disorders usually shows low IQ and more cognitive impairment and fewer repetitive stereotyped behavior. Coming on to the risk factors of the autistic spectrum disorders. Mainly it is genetic, sibling recurrence rate of 19%, and subthreshold autistic-like traits in relatives, especially in parents. There will be autistic-like features, but not amounting to the diagnosis of autistic spectrum disorder. Some of the traits, maybe phenotypes, are present. It is called a broader autism phenotype by IAP. Seen 20% in parents of autism and also in siblings of the autistic person. As we know, Fragile X syndrome, tuberous sclerosis, neurofibromatosis, all other are associated with autism spectrum disorder. Many other chromosomal abnormality disorders are associated with autism spectrum disorders. And chromosome 7q and 15q are most commonly implicated in autism spectrum disorder. Specific findings regarding neuroligin, SHANK3, contactin associated protein, neurexin-1, FMR1 gene have provided insight into the molecular and cellular pathology, especially pointing to the critical role of synaptic formation and function. As all we know, autism is a heterogeneous condition and the multiple genes have been implicated involving the chromosome 2, 4, 7, and 50. There are duplications of chromosome 15q, 11, 13, duplication and deletion of 16p11, and deletion of 22q1113, each of these accounting for about 0.5 to 1% of the cases. And common variants in 5p14 locus that reside close to the cadherin genes, cadherin 10 and 9, associated with high risk of autism spectrum disorder. Copy number variation in genes involving ubiquitin system is associated with high risk of autism spectrum disorder. Environmental factors are also studied, but with limited evidence. Obstetric complications like prematurity, hypoxia, bleeding during pregnancy, neonatal encephalopathy, and maternal diabetes are studied, are associated with, have shown some consistency across the systematic reviews with autism spectrum disorders, but the odds ratio is low, less than 3. And exposure to pesticides like thalidomide showed 50 times more than the non-exposure. The incidence of autism spectrum disorders is 50 times more with exposure to thalidomide than the norm. And with anti-epileptic or mood stabilizer of sodium valproate showed 8 to 18 times more chance of having autism spectrum disorder. Advanced maternal and paternal age, maternal age more than 30, paternal age more than 50 is recognized as a risk factor for autism spectrum disorder. Coming on to the psychological theories, there is lack of theory of mind. Theory of mind suggests that we can, theory of mind is a cognitive ability with which we can relate to the other's mental state, their emotions, their attributes, their thinking, their intentions, like that. So in autism spectrum disorders, there will be lack of theory of mind, that is inability to attribute mental state to others, failure to understand that other people may see things from a different angle, and there will be difficulty in predicting others' behavior. So it is usually associated with the identified mirror neurons. Mirror neurons are seen in premotor cortex, supplementary motor area, and inferior parietal lobe and primary somatosensory cortex. There will be mirror neuron deficiency as suggested in autism spectrum disorders. And there will be problem with the executive functioning. Executive function problems in sequencing, organizing, planning ahead, which are the functions of the prefrontal cortex. And there will be lack of central coherence. That means there will be difficulty in linking separate parts to make a coherent whole. That is, for example, separate sentences into a meaningful statement, and the cause and effect scenarios. Coming on to the neurotransmitters and neuromodulators. 20 to 50% elevated serotonin levels in blood and platelets, and there will be a difference in brain serotonin synthesis. Difference is in levels of oxytocin, which is usually implicated as a social hormone for attachment, bonding, etc. There will be low levels of oxytocin, and there will be hyperdopaminergic functioning of the brain, which might explain the overactivity and stereotyped movement. Enkephalins and endorphins might lead to the social withdrawal and unusual sensitivity to the environment, which is commonly seen in autism spectrum disorders. Neuroanatomical correlates. These are the affected area which are usually implicated in autism spectrum disorder. Amygdala, as you all know, functions as for emotional arousal, emotional perception, and emotional learning. And extended amygdala, ventral striatum, and nucleus accumbens forms the social reward circuitry. Fusiform gyrus is usually implicated in face recognition as well as social recognition. Superior temporal sulcus interpreting biological movement as nonverbal communication, including direction of eye gaze, facial expression, hand, head, and body gestures. Orbital prefrontal cortex, which is involved in emotional learning, and medial prefrontal cortex in social cognition, that is interpreting what others might thinking and feeling, and lateral convexity of the prefrontal cortex, mirror neuron network, and action comprehension. These are the areas which are involved in the pathology of autism spectrum disorders. Brain imaging may show increased head size and brain volume, mainly the frontal and anterior temporal lobes. And there will be reduced volume in bilateral amygdala hippocampus complex, and also the bilateral precuneus. Increased volume in the middle inferior frontal gyrus. Actually, the brain connects other regions of the brain are affected. Immunological theories are proposed for the etiogenesis of the autism spectrum. Unbalance the cytokine production, reduce the NK cell and T cell activation, increase the TNF alpha and interleukin 12, and increase the HLA-DR B14 and C4b null allele. Childhood vaccines have been quite a time. That was the main discussion among us causing autism spectrum disorders, but no evidence for that. And immunological incompatibility, maternal antibodies against embryonic neurons and extra-embryonic tissue have been proposed. Coming on to the assessment part, the core components, that is the social reciprocal communication, and the second one is the repetitive behaviors of or patterns of behavior, which can be motor or sensory or using an object or verbal. We have discussed all the three components under the heading of social emotional reciprocity, and 4 components under the repetitive behavior pattern. And we have discussed the diagnostic criteria. Developmental history is very much important in cases of all the neurodevelopmental disorders, especially autism spectrum disorder. Medical history, that is pre and perinatal problems, seizures, history of other genetic disorders are important. Physical examination, vision, hearing, congenital abnormalities, skin condition, evaluation of growth and head circumference is important. Coming on to the medical assessment in detail, physical examination, hearing and visual assessment, Woods Lamb examination for the signs of tuberous sclerosis, and genetic testing, G-banded karyotype, that is normal karyotype, and Fragile X testing, and chromosomal microarray testing, which can detect abnormalities clearly associated with increased rate of ASD, that is 15q1113 maternal duplications and deletions of chromosome 16p11.2 and other genetic variations. Coming on to the practical aspects, in all cases, karyotyping can be done, and neurometabolic workup has to be done because phenylketonuria, adenosine deaminase, genetic polymorphism, biotinase deficiency, folate deficit. A lot of metabolic disorders are associated with autism, like autism spectrum disorder-like symptoms. And if the next child is the concern, ASD panel can be done. It's a trio test which includes karyotyping, chromosomal microanalysis, and exome analysis. As you all know, many of the chromosomal abnormalities and syndromes are associated with autism spectrum disorders. Some of these are Tourette syndrome, Cohen syndrome, tuberous sclerosis, Angelman syndrome, CHARS syndrome, Fragile X syndrome, neurofibromatosis, Down syndrome, Noonan syndrome, Williams syndrome, like that. And coming on to the observational assessment, these specific tools are there. CARS is one of them, Childhood Autism Rating Scale, and other main investigations involve cognitive, sensory, perceptual, motor coordination, and psychological evaluation. There are a lot of scales for the assessment of autism, like ABC, Autism Behavior Checklist, which can be used as a screening tool in children. It is a parent-rated tool with 57 items. CARS, which is widely used as screening tool, Childhood Autism Rating Scale in children, it is a clinician rated with 15 items. MCHAT is a checklist for autism in toddlers, which is parent rated. And Autism Diagnostic Interview, which is a child or adult interview, which is also a clinician rated assessment tool. Coming on to the disability assessment for as per the Right of Person with a Disability Act 2016 and Gazette published in 2016, we use Indian scale for assessment of autism for disability assessment. It is used beyond 6 years, and it has 6 main core features. One is social relation and reciprocity. Second is emotional responsiveness. Third is speech, language, and communication. 4 is behavioral pattern. 5th is sensory aspect and cognitive components. So under these 6 headings, there are 40 test items which can be rated from 1 to 5 according to the severity, frequency of the thing. So we will get a minimum score of 40 and maximum up to 200. This is very important. Comorbidities are very common in autism spectrum disorder, and we have to identify and diagnose it as a separate entity according to the DSM-5. And comorbidities usually associated with autism spectrum disorders are attention deficit hyperactivity disorder, obsessive compulsive disorder, oppositional defiant disorder, tics disorder, mood disorders, anxiety disorders, intellectual disability, and epilepsy. Based on medical assessment, we can go for an EEG and MRI as the case may need. The EEG abnormalities and seizure disorders are observed in as many cases as 20 to 25% of individuals with autism. Coming on to the treatment plan. Treatment is individualized plan. Change in response to the child development. It varies after the child if the child grew, we have to change the treatment plan according to the child's development and skills. The treatment goals are to reduce the core symptoms and behaviors, which we already discussed, enable the individual to achieve their potential. That is very important. They may have many skills, so we have to enable, or we have to increase that skills they may have, and treat the comorbidities present and support the family. Specific behavioral interventions are proposed in autism spectrum disorder. One of them is applied behavioral analysis. Widely disseminated comprehensive applied behavioral program is early intensive behavioral intervention for young children based on the work of Lowas et al. And applied behavioral analysis has been found to be effective as applied to academic tasks, adaptive living skills, communication, social skills, and vocational skills. In applied behavioral analysis, we are trying to increase specific behaviors or maintain specific behavior, or we have to we can introduce new skills, and we can decrease the undesired, not non-desired behavior. Coming on to the educational intervention, that's a structured educational approach with explicit teaching, intensive and individualized interventions are better. There are two structured models which are studied. One is early start Denver model, and second is treatment and education of autism and related communication, handicapped children program, TEACH program. Early start Denver program is for children aged from 1 to 4 years, and it combines applied behavioral analysis teaching method plus developmental relationship-based approaches. An early start Denver model therapy for 20 hours a week, 15 hours by trained therapists and 5 hours by parents over a period of 2 years span. Another method is TEACH method, treatment and education of autism and related communication, handicapped children program. TEACH, developed by Drs. Eric Schopler and team in 1960, established worldwide in North Carolina legislature. It is designing sheltered settings that help children make use of the skills they already possess, rather than at helping children to enter a normal setting. Special education teachers set up workstation for each child. So here we are increasing the skills they already possess. We are making environment for the child to develop his own abilities. Social reciprocity, pragmatic language-oriented interventions are there. In infants or preschool child play organizers, that is neurotypical peers taught to encourage sharing, helping, and praising to facilitate play. Buddy skills teaches neurotypical peers to stay with, play with, and talk to their buddies. In school-age children, social stories state a problem and give the child an acceptable response to it, usually focus on maladaptive behavior. Peer network or circle of friends and social skill groups are arranged. Visual, scheduled or verbal rehearsal using written and pictorial representation of expected activities and behavior. And social thinking and training scripts are other methods. Coming on to the pharmacotherapy. Pharmacotherapy offered to children with ASD when there is a specific target symptom or comorbid condition. There are two FDA approved drugs. One is risperidone, which is a second generation antipsychotic. Another is aripiprazole, which is a third generation antipsychotic, which usually have a dopamine stabilizer role. These are the two drugs which are approved by the FDA. Risperidone, we can start at lower dose, 0.5 milligram, and we can titrate to increase the dosage. Aripiprazole, usually we start at the dose of 2.5 mg and we can increase. These drugs are usually used for the treatment of irritability, consisting primarily of physical aggression, self-injurious behavior, severe tantrum behavior, and hyperactivity associated with autism spectrum disorder. behavioral and educational interventions are needed, and parents should be educated that the need for the early intervention. കുറച്ചു കാലം കഴിഞ്ഞാൽ ഇതൊക്കെ മാറിക്കോളും, അതൊക്കെ ശരിയാവും, ഇപ്പൊ തന്നെ ഒന്നും ചികിത്സിക്കേണ്ട ആവശ്യമില്ല എന്നുള്ള രീതിയിലുള്ള ഇൻഫർമേഷൻ ഒരിക്കലും അവർക്ക് കിട്ടാൻ പാടില്ല. Sensory integration and auditory integration training has to be done. Antipsychotic, which I already mentioned, aggressive and for repetitive self-injurious behavior. Sleep hygiene should be taught to the autistic child, and treatment of comorbid mental health issues, that is anxiety disorders, mood disorders, tic disorder, obsessive compulsive disorder, attention deficit hyperactivity disorder, and epilepsy. And occupational therapy may be needed, play therapy may be needed, and speech therapy for the those who have language delay. Parent training is one of the most successful method, because the real world setting, the child is more involved in real world setting than a therapeutic setting. So parent training, and the parent has to involve in all the therapies I mentioned. With that, I would like to conclude, and thank you for giving me this opportunity.
Thank you. Thank you, Dr. Hani, for that excellent presentation, making it as simple as possible. Such a complicated topic, incorporating everything, including the newer advances. And I think as pediatrician, we must always screen these children for autism, especially when they come to the Wellbeing Clinic for immunization. And that's a golden opportunity. At 9 months and 15 months, they come for immunization. And there is no medical test for autism. So by mere observation, we can suspect. Most of the time, we can pick up this by just observing the child. So that's the most important thing to diagnose. It's a unpardonable mistake, I must say, to miss autism, because early intervention makes a whole lot of difference in the end. Anyway, this topic is open for discussion. Any clarification, queries, and suggestion you can make directly, or you can put in the chat box. And I think there is one question in the chat box, which is, how is ASD, autistic spectrum disorder, graded to get benefit under disability certificate? That's a question, Dr. Hani.
I already mentioned the Indian scale for assessment of autism. I mentioned 6 main headings, under which there is 40 tests. These 40 tests are rated from 1 to 5. And if it is below, the total score is below 70, that means there is no autism. If it is 70 to 106, there is mild autism. And 107 to 153, there is moderate autism. And more than 153, severe autism. And we can also calculate the percentage of disability. If it is below 70, no autism, I already mentioned. If it is 70, it is 40%. 71 to 88, 50%. 89 to 105, 60%. 106 to 123, 70%. 124 to 140, 80%. And 141 to 158, 90%. And if the score is more than 158, 100%. Like that, we can calculate the percentage of disability, and the disability we can assess in the medical boards. The faculties which should be present for the certification are: one is the clinical or rehabilitation psychologist, second is pediatrician, and third is psychiatrist.
Okay, so that question was from Dr. Prashant. Thank you for that clarification. Now, Dr. Jalil sir has asked one question. What is the real indication for the above mentioned two drugs, that is the risperidone and the other third generation antipsychotic?
As I already mentioned, in all cases, we will not give these drugs. If there is self-injurious behaviors like head banging, and if there is aggressive behavior, irritability, and maybe stereotypical behaviors also are amenable for these drugs. So all these conditions or associated hyperactivity also. In ADHD, we use this risperidone, but not as a first choice. But we use these drugs, risperidone and aripiprazole, in these conditions in autism spectrum disorder. I think I am clear.
Okay. That's very clear. See, anyone? Any other questions? See, I have a question, Dr. Hani.
Dr. Azan.
Okay.
Okay. Dr. Joseph Anthony. Thank you for your kind, clear-cut presentation. What is the minimum age that you can make a clinical suspicion of autistic spectrum disorder? One question. And there are so many conditions overlapping with the ADHD and autism in early stage, because sometimes we may not very difficult to say which is going, whether ADHD or early autism features. And the minimum age we can make a clinic, because so many kids are coming in a busy body. As Faisal noticed that when a well-baby clinic offer, you can sit laxly, you can suspect the movements of child, the repetitive movements, and etc. We can make a suspicion that is a child is because I had my own Rotary doctor child. They only suspected my child is little hyperactive and is like that, and they only pointed out to me, it's not about 1.5, I think 1.5 years old. And later it will be turned to be an autistic spectrum disorder. It is on treatment from Bangalore and so many other places. And what my question is that if you suspect like that, what is which time, minimum time we can send for neurometabolic workup or genetic workup if you suspect like that? All the cases, or any criteria for you send for neurometabolic workup and genetic like Zome and other thing? Dr. Azan?
Yes. The first thing, first part of the question was, what is the minimum age at which we can diagnose or at least suspect it? Or at least suspect autism spectrum features? The answer to the question is, from the early months of development onwards, that is the lack of social smile and lack of eye contact usually will be present before we can identify it before 6 months, I think. And after that, we can diagnose that there is a difficulty in joint attention. That is, if the parent is pointing at an object, but the child looks at the pointed finger rather than the object. These are present from the above 6 months year old child. We can see these features, and all other features, that is the social communication, or later only we can at about the age of 2 or more. So At the age of 3, we can diagnose with certain autism spectrum disorders. And we have to give intervention and treatment, and also the investigation start at this age, and we will go up to the age of 6 years for the disability assessment and other things. Okay. Now about the metabolic investigation, neurometabolic investigation, and other genetic testing and. Hello.
Yeah.
Am
Yeah. Audible.
Okay. I just want to tell you that it is depend on the clinician. If we suspect all the other, if there is dysmorphogenesis and other features of chromosomal abnormalities or metabolic disorders, symptoms of neurometabolic disorders, we can directly go for the test. Otherwise, no need to test in all the types. If it is benefiting the child, that means there is other features of neurometabolic disorders, we can directly go for testing of neurometabolic parameters and genetic testing also. And after all, the treatment is if we recognize the neurometabolic disorders and treat that, well and good. Otherwise, if it is not present, the treatment is the same. We will go for the behavioral approaches, educational approaches, and speech therapy, occupational therapy, play therapy, parent education, and all.
Thank you, Hassan, for your explanation.
Okay, Dr. Hani, I had seen some childhood psychiatrists recommending some special, dietary advices to these children. So is there any role for a special diet for autistics, or is there any role for restricting some diets in autism?
Casein-free diet as well as gluten-free diet. These are studied in autism spectrum disorders and has shown some of the evidences, but not up to the clear-cut evidence is lacking. And omega-3 fatty acids are better for the child with autism spectrum disorders. And there are some recommendation about basic magnesium, like that micronutrients are good for autism spectrum disorders, but all are lacking definite evidence.
Okay, also
Vitamin
you
Vitamin
go
D
on.
deficiency.
Yeah, that is also implicated. Vitamin D deficiencies are shown in studies. Some of the studies show hypovitamin D associated with autism spectrum disorder.
Okay. The another thing is you mentioned about enkephalin and endorphin, but is it the reduced values or it's increased in autistic children?
I think it is reduced value.
It's reduced.
Seen.
Okay.
So that the social withdrawal and social things are
Okay.
they are positive neurotransmitters.
Yeah, that's it. Okay. Thank you. Any other?
Some institutions are conducting some classes for these ASD children. Is it useful?
And I had the first part.
some institutions are conducting classes to groups of students with autistic spectrum disorders. Is it really useful?
The better thing is always an individualized plan for each child, because the symptoms and the skills vary in different individuals. So individualized plan is more helpful. But as I mentioned, structured plan, educational plan by the special education teachers in these schools can produce positive results and can increase the parents' knowledge about the disorder, and they can also be involved as a part of the therapy. So actually it's a teamwork. So the teamwork should include pediatrician, psychiatrist, rehabilitation or clinical psychologist, special education teachers, occupational therapist, speech therapist, and parents. This is a team for the working above the children with autism spectrum disorder. Each will have their diagnosis, and they will work it upon, and remedial education also should be given to these individuals.
What is clinical psychologist's role in the management of ASD?
Clinical psychologist first uses these tools, as I mentioned earlier, that observe there are clinician rated or observational tools which can be used by the clinical psychologist. They will have the role for screening as well as coming to a definite diagnosis, and we can write the symptoms also. After treatment, we will know the progress of the disorder, or progress of the development by again using the same scale. The difference between this pre-treatment and post-treatment score is important. Also, they can also do behavioral management. As I already discussed, applied behavioral analysis. That is the method to increase the desired behavior or decrease the non-desired behavior, maintain some behavior, introducing new skills. There are mainly 5 components for applied behavioral analysis. Task analysis, that is break down a complex task into small things, small steps, so that the autistic child can do the small steps and coming to the complex task later. Like ഇപ്പോൾ ഒരു ബ്രഷ് ചെയ്യാന്നുണ്ടെങ്കിൽ നമുക്കതൊരു സിമ്പിൾ ആയിട്ടുള്ള ഒരു ആക്ട് ആയിട്ടാണ് തോന്നുന്നത്. പക്ഷെ ഓട്ടിസ്റ്റിക് ആയിട്ടുള്ള ചൈൽഡിന് അത് ബുദ്ധിമുട്ടായിരിക്കും ചിലപ്പോൾ. അപ്പൊ നമ്മൾ ഒരു സ്റ്റെപ്പായിട്ട് നമ്മൾ ബ്രഷ് എടുക്കുന്നത്, ഒരു സ്റ്റെപ്പായിട്ട് പല്ലിൽ വെക്കുന്നത്, അല്ലെങ്കിൽ പേസ്റ്റ് തേക്കുന്നത്, അങ്ങനെ ഓരോ സ്റ്റെപ്പായിട്ട് കുറച്ചായിട്ട് ഓരോ ദിവസം നമ്മൾ കൊടുക്കുക. അതുപോലെ ഇങ്ങനത്തെ ഈ സ്മോൾ സ്റ്റെപ്സ് കണക്ട് ചെയ്യുന്നതിന് ചെയിനിങ് എന്നാണ് പറയുന്നത്. പിന്നെ നമുക്ക് ടു അവോയ്ഡ് മിസ്റ്റെപ്സ് അല്ലെങ്കിൽ പുതിയ സ്കില്ല് ഇൻട്രൊഡ്യൂസ് ചെയ്യാനായിട്ട് നമുക്ക് പ്രോംപ്റ്റിംഗ് എന്ന് പറഞ്ഞ ഒരു മെത്തേഡ് ആണ് യൂസ് ചെയ്യുന്നത്. അതേപോലെ തന്നെ നമ്മൾ കുട്ടിയുടെ ഇൻഡിപെൻഡൻസ്, അതായത് കുട്ടി ഒറ്റക്ക് ഈ കാര്യങ്ങളൊക്കെ ചെയ്യാനായിട്ട് നമ്മൾ പ്രോംപ്റ്റ് ഫീഡിങ് എന്നുള്ള ഒരു മെത്തേഡാണ് യൂസ് ചെയ്യുന്നത്. പിന്നെ നമ്മൾ ഷേപ്പിംഗ് എന്നുള്ള ഒരു മെത്തേഡ് യൂസ് ചെയ്യും. ഷേപ്പിങ്ങിൽ നമ്മൾ ഓരോ സ്റ്റെപ്പായിട്ട്, അതായത് ഇപ്പം ആപ്പിൾ എന്നുള്ള ഒരു വാക്കാണ് പറയുന്നുണ്ടെന്നുണ്ടെങ്കിൽ നമ്മൾ ആ എന്നുള്ളത് ആദ്യം പഠിപ്പിക്കും, പിന്നെ ആപ്പ് എന്നുള്ളത് പഠിപ്പിക്കും, പിന്നെ ആപ്പിൾ, അങ്ങനെ ഓരോ സ്റ്റെപ്പ് ബൈ സ്റ്റെപ്പ് ആയിട്ട് ഷേപ്പ് ചെയ്ത് കൊണ്ടുവരാനായിട്ട് പിന്നെ ഈ അപ്ലൈഡ് ബിഹേവിയറൽ അനാലിസിസ് വഴി നമുക്ക് ചെയ്യാൻ പറ്റും. ഇപ്പൊ നമുക്ക് ഇപ്പോൾ പീഡിയാട്രിഷ്യനോ സൈക്കാട്രിസ്റ്റിനോ ഇതൊന്നും ചെയ്യാനുള്ള സമയം ഉണ്ടാവില്ല. അപ്പോൾ ഓട്ടോമാറ്റിക്കായിട്ട് ഇത് ചെയ്യേണ്ടത് ഒന്നെങ്കിൽ ക്ലിനിക്കൽ സൈക്കോളജിസ്റ്റോ അല്ലെങ്കിൽ സ്പെഷ്യൽ എഡ്യൂക്കേറ്ററോ ആണ്.
Are there valid Indian studies regarding the incidence or occurrence of autism in Indian children?
Hello?
Are there valid Indian studies regarding the incidence and or occurrence of autism in Indian children?
I didn't find any valid studies. There are studies with NIMHANS and all, but
is it at par with Western occurrence?
I think we are not diagnosing autism spectrum disorder with that much pace as that is in Western countries.
CDC says that it is 1 in 59.
Yeah.
That studies.
I mentioned the latest study,
1 in 54 you have told.
1 in 53 is the latest study in 2020.
That is, these are all foreign studies, isn't it?
Yeah. Maybe that much incidence we have, but we are missing the case.
Okay. Any more questions?
ചാറ്റ് ബോക്സിൽ ക്വസ്റ്റ്യൻ ഉണ്ടല്ലോ.
ഉണ്ടോ? ഫൈസൽ ഇല്ലേ?
ഫൈസൽ ഉണ്ട്.
Hello. Yes, sir. I am here.
Chat box.
Okay.
There are two.
From Jasmine, the question is, which is the best tool that we can use in BCOP for correct diagnosis? Usually, patient is referred to without proper diagnosis. So, best tool we can use in BCOPD, I think, is correct observation only. And Dr. Hani?
Yes, sir. That is the answer. We can just take a proper history about the core features. We can use the DSM-5 tool. That is the 3 core features of social reciprocal communication plus 2 out of the 4 repetitive behavior. So we can simply diagnose with a proper history and the observation of the child. If we are not able, or we are suspecting an autism, we can definitely send the patient to a clinical psychologist for the writing scale. And one of the screening tool which is recommended by the Indian government is England Autism diagnostic tool. I think I can share after this class. I will Indian scale for assessment of autism. So in the BCOPD, we can definitely go for the DSM-5 criteria, which is mainly observational, and through history we can make the diagnosis of autism spectrum disorder, and we can send the patient to rating scales and
Okay. Vijayama sir, you have any comments to make? Vijayama sir? Vijayama sir, please unmute. Yeah.
Yeah, I don't have any comments. It was a nice, I was just listening to that talk. It was a nice discussion of the common problems and how a pediatrician can identify very early. And the use of MChat and all these things that is popular. I think we are using MChat here for early diagnosis, that 20 points and all of these things.
Okay, sir.
Using that.
Okay, sir. Thank you. Thank you for that information. Any more questions? If you won't have any other questions, I think we can wind up this session. Thank you all for the patient listening. Over to Dr. Sadiq.
Now, vote of thanks by Dr. Juman, our secretary.
Good evening, all. I hope I am audible. And Dr. Hani, it was a very interesting and really useful talk. And the discussion followed by talk was more interesting and more useful. So I would like to thank on behalf of IAP Malappuram for such a nice presentation and good talk. And also I would like to thank Dr. Vijayamon sir for who inaugurated this session, and all senior leaders, especially Josh sir, who participated in this program. Thank you.
So we'll end the program.
Okay, we'll leave it.
Okay, good night.
Good night.
Good night.
Good night to all.
Good night, Faisal.
Good night, sir. Good night, everyone.